We identified signs and symptoms of cystitis and pyelonephritis. We analyzed the results of a urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis, and we looked at the common uropathogens. Now, the next learning objective is, given a patient case, recommend effective drug therapy for treatment of cystitis or pyelonephritis.
The IDSA guidelines recommendations for treatment of uncomplicated cystitis. Here's what they say. So they say fluoroquinolones should not be used as first-line agents for cystitis, and that's because of the high propensity of collateral damage, and that's because fluoroquinolones are very broad. So ciprofloxacin and levofloxacin cover pseudomonas. So if you're not trying to cover for pseudomonas, you do not need to use a drug that covers pseudomonas, because that will lead to collateral damage. It will cause ecological changes in the flora in the patient. PO beta lactams have low efficacy in general, so they should be reserved as last line. Especially amoxicillin and ampicillin have been shown to have poor efficacy. But if you do, for example, if someone has allergy to our first line agents and you have no choice but to use PO beta lactams, your options are amoxicillin clavulanic acid, cefdinir, cefaclor, and cefpodoxime. But they should be reserved as last line. The IDSA recommends trimethoprim sulfamethoxazole or trimsulfa as first line option, but they do say that you should not use it if the resistance rate is more than 20%. And these guidelines were published in 2011, and since then we know that the resistance rate is actually more than 20% across the United States. So you should not use Bactrim or Trimsulfa for cystitis empirically. And the reason I say you should not use it is because in cystitis we do not get the urine cultures. So if you do not get urine cultures, there's no way to know if E. coli is susceptible to Trimsulfa. And because the resistance rate is more than 20%, you have more than 20% chance of failing treatment. So that's why you should not use Trimsulfa. Which means that we are left with two agents. So here are the two agents that are recommended first line by IDSA. So nitrofurantoin and fosfomycin. Now note that fosfomycin, you will give 3 grams PO just one time. So it's just a one dose and you're done with treatment. So that's very convenient. And nitrofurantoin, you have to treat for 5 days. So this is exactly why you do not need to get cultures for cystitis, because it typically takes at least 3 days to get the culture results back. So if you gave the patient fosfomycin, you're done with treatment. So what are you going to do with the culture? And if you're using nitrofurantoin, by the time you get the culture results back, you're on day 4. So it's just one more day left. So what are you gonna do with that urine culture? You're almost done with treatment. So there's no need for urine cultures in cystitis. And here are your two options. Now note that with nitrofurantoin, if someone's renal function doesn't work well, so if creatine clearance is less than, if the kidneys don't work well and creatine clearance is less than 60, it's basically contraindicated. And if fosfomycin is not available, or if it's too expensive, it's actually not that expensive. It might be like $40, $30 or $40. But if somebody couldn't pay for it and nitrofurantoin is contraindicated, that's when you are left with PO beta lactams. Like you go to cefpodoxime, for example. But if you can use these two, that's what you want to do because of the increased efficacy. PO beta lactams have inferior efficacy, but they'll work. You're more likely to get recurrent cystitis if you use PO beta lactams as opposed to these two agents. Now, a lot of doctors, of course, like to use ciprofloxacin because it's PO, but it's our job to remind them of the collateral damage of ciprofloxacin, and they should not use ciprofloxacin. Unless you had to. So if a patient had contraindication to nitrofurantoin and fosfomycin wasn't available, and they also had like beta-lactam allergy, and then sure, eventually, if you have nothing else left, you can use ciprofloxacin. But when you have these options available, you should not use fluoroquinolones. Now, for pyelonephritis, again, the same goes for Bactrim or Trim-sulfa. Empirically, you should not use it because resistance rate is more than 20% across the US. But if you get your culture results back and it says that it is susceptible to trimethoprim sulfamethoxazole, then you can use it, but not empirically. Also with fluoroquinolones, empirically you should not use them because resistance rate is more than 10%. The threshold for fluoroquinolones is 10%. The threshold for trim-sulfa is 20%. So empirically you should not use ciprofloxacin. But once your culture results come back, you could potentially use it, but it's not first line, again, because of collateral damage. Now, in pyelonephritis, you should have urine culture, so that helps us. Whatever you chose empirically, we're gonna, once you get the culture and susceptibility results back, we're gonna use directed therapy. So, which means that, because empirically you cannot use fluoroquinolones and you cannot use trim-sulfa, what you can use is third generation cephalosporins. So, ceftriaxone is the #1 agents that you will see used until the culture results are back, and then you can de-escalate from ceftriaxone to something more narrow. Now here's the resistance. So let's take a look at the changes in resistance rate of E. coli across the United States. So here we're looking at 3 different agents. So nitrofurantoin, trim-sulfa, and ciprofloxacin. They have also separated it by age groups. So elderly, ages of 65 years or older, and younger. And then, so they're comparing what the rate was in 2003 and what the rate was in 2012. And this was published in 2016. So it takes a few years to collect all this data and get it published. So that's why this goes up to 2012. So when you look at nitrofurantoin, you can see that there wasn't much difference. There was basically no significant increase in resistance rate between 2003 and 2012. So that's why nitrofurantoin is a really good agent to use empirically. When you look at trim-sulfa, you can see that in 2012, for both age groups, the resistance rate is more than 20%, which is more than the threshold that the IDSA recommends. So that's why trim-sulfa should not be used empirically. The same goes for ciprofloxacin. In 2012, the threshold is 10%, so definitely over 10% for both age groups. That's why Cipro and Bactrim should not be used empirically. Nitrofurantoin can be used empirically for cystitis only, and I'll mention why cystitis only in a little bit. Here are the formulation for nitrofurantoin. So back in 1952, when we first came up with nitrofurantoin, it was in macrocrystalline formulation. It had really good absorption, but it also had increased GI effects, adverse effects, which led us to developing a macrocrystalline formulation. This improved the GI adverse effect, but the absorption wasn't as good. So that's why with macrocrystalline, we have to dose it 4 times a day because it's not absorbed. So you have to do it multiple times throughout the day. Until later, we actually, when we develop macrobed, that's a combination of macrocrystalline and macrocrystalline. So, improves absorption and also improves GI adverse effects. And this is dosed twice a day. So 100 milligram 2 times a day. And here's the spectrum of coverage of nitrofurantoin and fosfomycin. So they do cover enterococcus, which you would suspect in UTIs as well as VREs. They also cover VRE, and also they have good coverage for E. coli. So that's why these 2 are excellent agents to use in cystitis. And resistance rate has not increased over the years. Because there are different formulations of nitrofurantoin, and if you're working with the generic, it just says nitrofurantoin on it. So it's important to be able, as pharmacists, to distinguish between the 2 formulations. So as you can see, choice A, it actually tells you that this is monohydrate macrocrystals combination, whereas the second is just macrocrystals. So this question is which is the generic for macrobid. The correct answer would be A. It also tells you here, so A is macrobid. It says that it's dosed twice a day, take it with food. Whereas the second option, it tells you, let's see, QID, so 4 times a day with food. So that's how you know choice A is macrobid. So as pharmacists, you should be aware of, if the doctor wrote for macrobid, don't dispense the second option, especially if the instruction says take 1 pill twice a day. You do not want to give them this because it's not going to be absorbed as much and you're going to have failure, treatment failure.